Okay, we'll start. It's already 2 p.m. Welcome all. Please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of the companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group picture taking at the start and at the end of the pep talk. So please show your face in the video during the picture taking. As a reminder, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. The link has been placed in the chat box by Ms. Beto Tumambing. Okay. Below is the picture of the certificate that will be issued to you once you pass the OLETE. Also, as a reminder, getting 50 OLETE certificates, okay, will entitle you to 1 voucher for free telemedical consultation. So let's now have a group picture taking before we start the pep talk proper in 2 minutes. Please turn on your video and show your face. Okay, 1, 1, 2. Okay, everybody ready? Okay. I cannot wait anymore. 1, 2, 3. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. October 23, 2021 onwards, I've been tackling health disorder and health issue courses. So this may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Breast Cancer, Part 2. This is the part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of breast cancer. Let's have some definition of terms in the title and the limitation of the coverage of my talk. When you say fundamental, this will be used to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced and more information in the future. Generalities mean general statements of information, not covering specifics and not too detailed. Medical management, specifically on breast cancer, will be diagnosis and treatment of breast cancer, usually done by physicians. I have discussed part 1 last week, and now we are on part 2, okay, which will include the following: treatment, surveillance, prognosis, palliative and hospice care for breast cancer patients. Let's start with treatment for breast cancer. After formulating the pre-treatment diagnosis, including determining the extent of breast cancer and other factors with effect on the treatment, the first thing to do, to be done by the physician before considering and comparing the options of treatment methods or modalities is to spell out the specific objective or the goal of the treatment, whether curative or palliative. Curative goal means eradicating known tumors and cancers entirely, completely, preventing the recurrence or the spread of the primary cancer. Whereas palliative goal means relieving symptoms if all or after all reasonable curative approaches have been exhausted. As at the time of the treatment, a patient may present in a cancer stage in which the goal is at best palliative only, relieving symptoms. So these are usually patients with advanced, very advanced cancers. For patients presenting with early stage cancers, the goal is curative. It should be curative, that is eradicating the cancer entirely and trying to prevent recurrence or spread of the primary cancer. Thus, the objective of treatment is primarily dependent on the stage or extent of the cancer at the time of treatment. Staging and stage of cancers, okay, this just means describing the extent of a cancer. Okay. There are so many ways of staging cancers. The simplest is to classify it into early stage and advanced stage. Another classification will be localized, regional, and distant. The other one is localized, early locally advanced, late locally advanced, and metastasized. And then the TNM staging, which describe the size of the cancer and how far it has grown. At the moment, in the medical world, this is the most popular, okay, the TNM staging. Okay, T stands for tumor, N stands for nodes, and then M stands for metastasis. When you have stage 1, the tumor is localized, limited, okay, no nodes yet, no distant spread. When you have stage 4, it has already spread to distant organs like the brain, the lungs, and the bone. Okay, in between stage 1 and stage 4 are stage 2 and 3. Okay, there are at the moment for breast cancer. Probably in some other cancer, it will also follow, but at the moment, it has included the prognostic staging aside from the anatomic staging. The minimum, the very least in the staging system is that it should have the anatomic staging. Okay? So lately, with the advanced technology, we have come out with prognostic staging. So anatomic staging means this is defined by areas of the body where the breast cancer is found. Okay, just like the TNM. Okay, prognostic staging is how likely a patient is to be cured of cancer, assuming that all the appropriate treatment is given. So this is a illustration of the anatomic staging for breast cancer. Okay, stage 0, 1, 2A, 2B, 3, 3A, 3B, and then 4. As I said, once you have M, it's already stage 4. So in breast cancer, the more common sites of metastasis are the bones, lungs, liver, and brain. Okay, if you have stage 0, it means it's still localized to the milk ducts. No, and the other term is ductal carcinoma in situ. Okay, for stage 1, usually there's only one T and smaller. There's the T which is smaller than 2 cm, and then there's no nodes, no distant metastases. Okay. For T stage 2A and 2B, the difference is that the size, mainly the size, okay, plus the lymph nodes. The presence of lymph nodes automatically makes it stage 2, but the size can vary. Okay, but usually it's less than 5 centimeters. Okay. Now, stage 3 are the so-called locally advanced breast cancer. An illustration of the prognostic staging system for breast cancer, which is commonly used nowadays. No, this make use of the information that are gotten from the receptor assays and HER2, okay, which can predict prognosis. Okay, ERA means estrogen receptor assay. PRA, progesterone receptor assay. HER2 is human epidermal growth factor receptor A. So based on the examination of the tumor, okay, if it's there's one category of staging here in terms of prognosis: ERA positive, PRA positive, HER2 new negative. This carries the best prognosis if you have this information on the tumor. Okay. Now, if you have ERA negative, ERH2 negative, this is what is called triple negative. This has the poorest prognosis among the four groups. There are a lot of cancer treatment being advocated. Mainstream ones and non-mainstream ones. Mainstream ones are those accepted and being promoted by majority of the physician cancer specialists. That's why it's also called conventional or standards. And it has well-documented evidences of effectiveness, although in varying degrees, not always 100%. Non-mainstream ones, meaning non-mainstream just mean outside the mainstream ones, or the so-called alternative medicine. And then the health claims here are not usually meeting the evidence-based standards. The mainstream modalities of treatment for breast cancer are the following: surgery, okay, meaning operation. Okay, essentially the process is cutting. Radiotherapy, making use of radiation, burning the tumor. Chemotherapy, using drugs to kill the cancer cells. Hormonal therapy, hormonal manipulations. Immunotherapy, immune system manipulation. And targeted therapy, gene manipulation. The alternative medicine is defined loosely as a set of products, practices, and theories that are believed or perceived by the users to have healing effects of the medicine, but whose effectiveness has not been established using scientific methods. That's why it's still called alternative medicine. The commonly used non-mainstream or alternative medicine treatment for cancers are the following: herbs and herbal medicine, special diet, supplements including vitamins, high dosage of vitamins, acupuncture, lifestyle medicine without the use of drugs, but relying on healthy living, healthy eating, physical activity, and other healthy behaviors. Words of caution on alternative medicine for breast cancer or other cancers for that matter. Delaying surgery, radiation, chemotherapy, and other traditional treatment by using an alternative therapy can allow the cancer to grow and spread to other parts of the body. And evidence have shown that people who use alternative therapies in place of standard cancer treatment have higher death rates. In a study, a 2017 study, and there are more studies coming up, after a median of 5 years follow-up, patients with breast or colorectal cancer were nearly 5 times as likely to die if they had used an alternative therapy as their initial treatment than if they have received conventional treatment. The mainstream modalities of treatment for breast cancer can also be classified into localized and systemic. Localized treatment means that the treatment are directed to the local area or specific limited area, such as the breast and armpit. So example of localized therapy will be surgery and radiotherapy. Systemic therapy are those using drugs and other chemicals that spread throughout the body to treat breast cancer cells wherever they may be. So this includes chemotherapy, hormonal therapy, targeted therapy, and immunotherapy. The breast cancer treatment may be single or combined modalities depending on the extent and track records of effectiveness. So one may use localized therapy alone if the tumor is really small and localized. Example of localized therapy will be surgery or radiotherapy. If it's widespread already, and then the tumor cannot be operated on or cannot be radiated anymore, then systemic therapy is used. But if the tumor can still be operated on, you can do the localized therapy, either radiotherapy or surgery, plus the systemic treatment. Okay, so examples of combinations of treatment here will be surgery first, then followed by chemo, followed by radiation. Another regimen will be chemo first, then surgery, then chemo, then radiation. Or another combination will be surgery first, followed by hormonal therapy. Any cancer treatment can be used as the primary treatment, but the most common primary cancer treatment for breast cancer is still surgery, especially those in the operable stage. Other combinations of treatment are done depending on the anatomic stage, prognostic stage, and other factors like track records of effectiveness. There are many types of operations: radiotherapy, chemotherapy, hormonal therapy, and other types of therapies. So for the operations, you have these options depending on the extent, depending on the decision of the surgeon and the physician and the patients. Total mastectomy, subtotal mastectomy, not removing all the parts of the breast, axillary dissection, and axillary sampling. Examples of radiotherapeutic regimens will be external beam radiation therapy and brachytherapy. For chemotherapy, it can be used singly or multiple. Most of the time, it's multiple, meaning in combination. So you have different combination like CMF, CAF, and taxane, and docetaxel. Okay. CMF, its letter here represent the first letter of the drugs, cyclophosphamide, methotrexate, 5-FU. Okay. Hormonal therapy can include the following: tamoxifen, letrozole, anastrozole, exemestane, and then other therapies like trastuzumab and fulvestrant. After the physician has decided on the goal of the treatment, he gives or lists the various options of treatment and then gives data on the BRCA, okay, benefit, risk, cost, availability. With the data given, the patient is asked what or she prefers. Example of BRCA comparative analysis of treatment procedures. Option 1 has the greatest survival rate compared to option 3, which has the least survival, and then option 2 in between. Okay. Assuming that the risks are all acceptable to the patient and can be tolerated, and then the cost is 5,000 for option 1, 6,000 for option 2, 3,000 for option 3. And assuming that all are readily available, so the best option here will be giving priority to the goal of the treatment, which is the benefit, greatest survival rate. So the best will be option 1. Okay? And then the cost is acceptable at 5,000. Surveillance of breast cancer, the next topic. Surveillance just means monitoring for 1, recurrence after all evident cancers are eradicated, okay, what is called curative treatment, and monitoring for progression or regression after palliative treatment, if the curative treatment cannot be done. Okay. The common issues or questions being asked: by whom, how long, how often, what methods. By whom? Usually the oncologist, okay, and some can put in the family physician to help them, okay. So the criteria to choose will be competence, whom you prefer, meaning preference by the patient. Okay. The basis will be the following: competence of the oncologist or the physician, expertise, professionalism, holistic and compassionate care, cost, okay, the professional fee, availability, and convenience of consulting him or her, etc. When you say oncologists, these are doctors with specialty in cancer management. There are various types. There's no such thing as only one type of oncologist. The surgical oncologists are those surgeons who specialize in treatment of cancers. Medical oncologists are those physicians, usually internists, who specialize in the management of cancer, usually giving drugs. Okay, this surgeon usually operation. Radiation oncologists are those which specializes in giving radiation to cancer patients. Okay, there are others. Others could be, okay, there's such thing as pediatric oncologists, gynecologic oncologists, and hematologists, etc. Okay. So one may choose one or more as indicated and as preferred. You can choose one to orchestrate everything, okay? And then when you choose one or two, okay, you use this basis as for your selection, for your decision making. How long should the surveillance be? Okay. For those with curative treatment goal, it's a lifetime, okay, surveillance, as all cancers have the potential to recur even after a long period of time of remission, okay, even after 10, 15, 20 years. And then for those with palliative treatment goal, there are three scenarios here: until signs of progression and regression occur, until a call or a decision is made for hospice care to be made already, okay, no more aggressive treatment, and then you can monitor it up to the end of life. How often? Two situations: monitoring for immediate results of treatment and monitoring for recurrence after curative treatment. For monitoring for the results of treatment, usually the monitoring is done for the side effects and complications of treatment, like surgery, the complications of surgery right after the operation, complications of chemotherapy and radiation. And then the other thing to monitor is the response to the treatment, okay? Particularly for chemotherapy and radiotherapy, to see if the tumor is shrinking or not. The duration of monitoring will be dependent on the type and duration of the treatment, okay, whether it's surgery, chemotherapy, radiotherapy. The recuperation time, expected response time, such as 2 to 3 months after chemotherapy, etc. And the frequency as to how often, so it depends, but it ranges from daily to every month, with an average of 6 months or even longer, as indicated. For the monitoring of recurrence of cancer after a curative treatment, it depends on the type of the cancer, treatment done, usual prognosis, time of treatment, whether the surveillance is at a time that it's soon after the treatment or long after the treatment, and then also the mindset and personality of the patients, etc. As a general guideline, the monitoring for recurrence after curative treatment for cancer will be more often for those with higher risk for recurrence, such as if the cancer is of the aggressive type, so you expect a high risk for recurrence soon enough, quite soon, then more often will be the monitoring frequency. And then if it's early post-treatment, say 1 to 2 years, when recurrence usually appears, majority of recurrence for cancer after treatment usually appears within the first 2 years, okay, or even some within the first 5 years. Okay. And then the other factor to consider, the guideline would be anxious patients who need frequent psychological support from physicians. If this be the setting, then the monitoring will be more often to take care of the psychological support care of the patients. What methods? Two methods: symptom sign directed surveillance approach and regular screening with the battery of tests approach. When you say symptom sign directed surveillance approach, it means that the patient's symptoms, what she feels, and then the physician signs what the findings of the physician on physical exam. All the both will direct or will dictate what instrumental laboratory test will have to be done. Okay, so it's not an outright doing instrumental laboratory tests right away. And then the regular screening instrumental laboratory diagnostic test directed surveillance approach. This means there's a battery of screening tests on the possible sites of recurrence. Okay, so these are done even in the absence of symptoms and signs. The physician gives or lists the options of surveillance. Okay, basically two: symptom directed, battery of test directed, and then gives the data on the BRCA again. So with the data given, the patient is asked what or she prefers. Okay. So when you talk about surveillance for breast cancer, then comparing these two methods, for the benefit, you have to take note of these three factors. Okay. In terms of early detection, which has the better advantage. In terms of survival, which has the better advantage or the same. In terms of quality of life, which has the better advantage. So example of information data that are being published, okay, on the two methods of surveillance: symptom directed and symptom sign directed and battery of test directed. Okay, so for the option one, between option one and option two, in terms of early detection, of course, when you do a battery test, you tend to find a lot of things. So it has the better advantage of detecting cancer earlier. Okay. Now for the survival, how long they will survive for option 1 and 2, studies have shown that survival rates are the same. This is for breast cancer. Huh? Okay. And then for quality of life, okay, which one is better? It's said that option 1 is better compared to option 2. Okay. Although the option 2 will have earlier detection, okay, but the patient is suffering for a long time because they die at the same time. Okay, so that is what it's meant by poorer quality of life for the second option, which is the battery of tests. Okay, so because of a lot of tests, there's a high risk for false positive results in the laboratory tests, and then of course in terms of cost, because of the battery of tests. This one, the battery of test directed surveillance, has the highest or higher cost. Okay. Prognosis of breast cancer. Prognosis just means the estimate on how cancer will go for you, for each of the cancer patients. It means the likely course of cancer without treatment, and if with treatment, whether curative or palliative, what is the likely outcome? And what are the chances of recovery? That's another way of looking at it. What are the chances of response to treatment? Okay, either cure or recurrence. And then making use of the 5 to 10 year survival rate data and the median survival rate data. In general, the prognosis of breast cancer is dependent on the type. Okay, example, sarcoma. Breast sarcomas have better, poorer prognosis than adenocarcinoma. Stage of cancer, stage 4 has the poorest prognosis. Inherent biologic behavior of the cancer, with or without comorbidities on the patients, which might affect the treatment and also the gravity of these comorbidities. And then, of course, the track records based on data available of the cancer. Okay. So, usually in the medical world, we usually use 5 to 10 year survival rates and also the median survival time of the different cancers. Okay, and then this can be data can be segregated into by stage of the cancer. What is, let's say, stage 1? What is the 5 year survival rate? Stage 2? What is the 5 year survival rate, etc. And then with or without treatment. Again, what is the 5-year survival rate with treatment? What is the 5-year or 10-year survival rate without treatment? When you say 5 to 10-year survival rates of cancer, it just means the percentage of cancer patients who are still alive 5 years or 10 years after they were diagnosed or treated. So this is an example of the 5-year breast cancer survival rate. Okay, so this may change over time, but practically it has been there for quite some time. Okay, so stage 0, close to 100%. When I say close, it's not always 100, it's probably 99. Okay, and then stage 1, 98% at 5 years. Stage 2, 5-year survival rate is 93, lower already. Okay, and then stage 3, 72%, and then stage 4, 22%. So this table shows the data that's gotten for 5-year, 10-year, and 15 years. Okay. The median survival of cancers means the length of time from either the date of diagnosis or the start of treatment for a cancer that 50% or half of the patient diagnosed with the cancers are still alive. Okay. They usually measure this in terms of months, but sometimes it can be measured in terms of years. Okay. So the median survival time can be calculated based on with treatment or without treatment, and also based on the stage and based on the types of metastases. Okay. So let's say stage 4 breast cancer. Okay. So the 5-year survival rate is about 20%. Okay. In that table that I gave is 22%. Okay. Then you input the put in the median survival rate. Let's say the data is about 3 years. So you now have information on the prognosis of a stage 4 cancer. Okay. So in terms of survival rate when there is already metastasis. So an example here, okay, for patients with brain metastasis, the median survival rate is 8 months. Okay. And then for those with bone metastasis, longer, 36 months. Okay. So it all depends on the site of metastasis. Now, if there's only one, okay, but usually it can be multiple, meaning liver and also including the lungs. Okay. So I got hold of this article now just to show you that nothing absolute in the prognosis or even medicine. There are exceptions to the rule. Okay. So here is a patient who has survived now for a long time, even with metastatic breast cancer. Okay. So we mentioned about the stage 4 survival rate is 22, 5-year survival is 20%, and then the median survival is about 3 years. Okay. So here, a 2-time cancer survival became the oldest living American. Okay. She turned 144 years old in October. This is this year. This is 2021. She now holds the records of the oldest living American, as the previous record holder died recently at age 116. Okay. She survived breast cancer twice during her lifetime. But this just goes to show that there are exceptions because to the rule, to the statistics. No? Last topic would be palliative and hospice care for breast cancer patients. 2 terms that one can encounter in the medical management, which most Filipino lay people are not familiar with, and which most doctors do not acquaint their patients with. So the 2 terms are palliative care and hospice care. Palliative and hospice care are being used in patients with advanced cancer patients, any type of cancer patients who have little or no prospect for cure and who are expected to die, and for whom the primary goal is just to optimize the quality of the remaining life on Earth. Both palliative and hospice care provide comfort. Okay? They have something in common, okay, in terms of physical, mental, and spiritual comfort. Okay? The difference between palliative and hospice care is that palliative care starts first. It can begin at the diagnosis and at the same time as the treatment, and it can consist of anti-cancer treatment. Okay, the active anti-cancer treatment. Okay. Hospice care begins after treatment of the cancer is stopped. Okay. So let's say somebody declared that no more anti-cancer treatment because it is quite evident, although not 100% sure, 99% probably the person is not going to survive the cancer, then there's a call for hospice care already. Okay. So here, this illustration shows start with advanced cancer. Okay, so with advanced cancer, you don't have curative goal, you just have palliative goal. Then you start with palliative care, still with using anti-cancer drugs, hoping for a resolution or improvement. And then if the anti-cancer, the palliative care is not effective anymore, then you can call for a hospice care in which there's no more anti-cancer treatment, just go by the natural means, natural methods of treatment. So summary and takeaway. I have discussed the part 2 in these sessions, which include the following: treatment, surveillance, prognosis, and palliative and hospice care for breast cancer patients. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on fundamentals and generalities in medical management of breast cancer. As we all know, knowledge is power and it gives power. Please use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of breast cancer. So with that, I end my pep talk, Fundamentals and Generalities in Medical Management of Breast Cancer Part 2. I hope I have enlightened you, okay, to have a better understanding of the fundamentals and generalities in the medical management of breast cancer. So before we go to the question and answer session, please, as a reminder, please take the online Learning Cube Evaluation Test exercise for mastery of learning and have a perfect score to get a certificate. Okay. I've seen the link placed in the chat box already by Ms. Beth Namambing. Okay. And then again, reminder, try to get 50 Alete certificates if you want to have a voucher for a free ROJoson telemedical consultations. Okay. So with that, let's now have a group picture taking before we have the question and answer sessions. Okay. Show your face. Evelyn, Abigail, Angie, Aida. Okay. Ready? Marianne, you don't like to show your face? Aida, I'll just put this. 1, 2, 1, 2, 3. Okay, I think we only have one page. Okay. The floor is now open to questions, comments, suggestions, and anything that you want to share with us.